The mission of the T. Leroy Jefferson Medical Society is to improve the health and wellness, access to care, academic and career opportunities, and the quality of life for underserved populations through the provision of healthcare, education, career exposure, and youth development services. We focus on elevating the professional success of our members through information, education, and networking opportunities. Our vision is to be recognized as the authority and trusted voice leading resources for health and wellness of the underserved in Palm Beach County, and to be the preeminent advocate fostering the advancement of minority health professionals. Welcome to the T. Leroy Jefferson Medical Society podcast, Helping the Helpers. Welcome to today's topic. We're looking at anxiety and depression in medical professionals. My name is Dr. Debbie. I am a licensed marriage and family therapist in the state of Florida, and I have the opportunity to be your host today. We have 4 incredible professionals throughout the mental health profession, and we're going to give them an opportunity to give us some encouragement, to give us some empowerment, and to give us some time just to pour back into ourselves. So our first guest with us today is Mr. Markin Balami. He is of Bedrock Counseling. And so, Markin, can you tell us a little bit about your specialty?
All right. Yes, my specialty is EMDR therapy, which is definitely trauma related. I'm an EMDR trained therapist, an EMDR certified therapist, and also a consultant where I consult with other licensed clinicians as well that are trying to improve on their craft of EMDR therapy. And I just pretty much love everything that's entails about trauma, whether that's the brain and body connection, whether that's someone wanting to have more language of what's happening internally within their bodies, within their minds. So everything about trauma is definitely something that grabs my attention. And of course, it can show up as other things as far as anxiety, depression, but I think a majority of the mental health diagnoses, mental health illnesses are somewhat have a trauma connection to them on some shape, form, or fashion.
And Markin, how many years have you been practicing, and why did you decide to go into this area?
I've been practicing for about 8 years as a licensed mental health clinician. And the reason I chose this area of practice is because it's kind of personal to me. I'm someone I've battled a lot of trauma growing up from childhood to adulthood. In my early 20s, had really bad PTSD. I was robbed at gunpoint. And I remember years later coming into this field and starting to learn as a therapist what are the symptoms of PTSD, acute stress disorder, and other trauma-related disorders. And I started saying, wow, I have a lot of these symptoms. And that started a deep dive in more conversations with other clinicians and eventually going to therapy for myself and learning how to notice more what's happening internally in my body, learning how to calm my nervous system, learning what are intrusive thoughts, what are flashbacks, why do I always feel safe, where are all these negative beliefs coming from, and just learning to feel safe in my own body and also in my surroundings. And the thing that did it for me was going to EMDR therapist. And once after a couple of sessions, I saw how quickly and effective it was. I said, I definitely want to get trained in that. So that's what really started me on this journey of becoming a trauma therapist. Number one, it was kind of personal for me, but number two, seeing the quick results of my clients, it just brought a sense of purpose to me. So that's something that I'm really passionate about.
Very nice to learn a little bit more about your passion and your purpose around this area. I wonder, from your culture, though, what really brings you joy?
That's a great question. From my culture, what brings me joy? I think that's a two-part question for me because although I grew up in the African-American context, My ethnicity, probably butchering this word, but my ethnic background is first generation Haitian American, and they're two completely different cultures. I'll start with the Haitian American background, to where mental health is never discussed. It's always layered with a sense of mysticism, or someone's just completely out of their mind. So it's never discussed as far as I'm functioning day to day, but there are still some microaggressions that I'm battling that are really weighing me down, or stressors in my life that after a while I'm not handling well. There's never been that type of conversation. And from my Haitian background, it's always been, if someone's completely out of their mind, it's either they were born that way, or maybe someone put a spell on them and went to the witch doctor, but it was never contextualized in a way to where, you know what, so-and-so's grandmother used to act this way, and I saw the same issues in their child and also in their grandchild, to where these things were hereditary and they were within the bloodline. So there were never those type of discussions. It was always either you're crazy, excuse me for using that term, but I'm just using that example. They would use the term either you're crazy or someone put a spell on you. But as time went on, I realized that, wow, the same way there's a stigma with mental health in the African American community, there's the same thing in the Caribbean community as well, from my context. And it was viewed as being weak, and the discussions were never really spoken. And if someone did have a legitimate mental health issue, they just kept it quiet. They didn't want people to know. It came with a certain level of shame. And I think that's one of my goals as a therapist is to destigmatize mental health in general, whether it's from my Haitian American background or from the African American context. I think the more we have the conversation, the more we'll begin to normalize mental health. Even me, for example, I still see a therapist just to make sure I'm okay, because in my field, there's just a high level of burnout. And sometimes I'll put it in my everyday language. If someone's trying to meet with me, I'll say, you know what, I can't do that day because I got to meet with my therapist. I purposely do that because I'm trying to normalize, like, you don't always have to be in crisis to go to therapy. We don't take our cars to the mechanic only when it's broken down. If you need an oil change, if it's time to make sure your fluids are regulated, or your tire pressure need a little adjustment, we'll take our cars to the mechanic shop. It's not always because we need a new engine, a new transmission, or it's just not starting. So I always try to encourage that mental health should be looked upon as preventative, so that we won't have to get to a state of crisis if we do a lot of work on the front end for the preventative care. And I think that's something that could be a lot of very beneficial to people in the medical field. It's a profession where there's high burnout because you're a first responder, and making sure that you're okay, you're centered, you feel a sense of homeostasis in your nervous system, to where you're calm, cool, and collected, and you feel like you have everything under control. I think it's much needed in the field of first responders, whether that be mental health, medical doctors, whether that be law enforcement, firefighters. We all need to make sure that we're doing these daily mental health check-ins. And I would say the second part of that question, what brings me joy, is seeing my people from the African American context, normalize the conversation of mental health and reach out. I never really say this, but whenever I get a call for a consultation, and it's either an African American man or an African American woman, or even someone of Haitian descent on the phone, and they're inquiring about mental health, I always think in the back of my mind, whether they come to me or not, I'm excited because they're inquiring about mental health. So that I feel like the conversation has definitely started. And I encourage them, even if they don't want to see me necessarily for therapy, I ask them, how can I be a bridge? Can I refer you to someone else? I'll even give them other directories, because I'm encouraging them to not give up on their search for a mental health therapist that they could really connect with. So it brings me joy seeing people who look like me, talk like me, and have somewhat of a cultural connection with me, inquire about their own mental health, and seem to be passionate about getting help.
So nice to hear all of the things that bring you joy. And, the last few years feels like joy has been far from many of the clients that we serve, and even professionals. What have you seen in this space?
Okay, that's a great question regarding COVID. How you mentioned the last few years, it feels like joy for many. The clients we serve, there haven't been much of that in this profession. Uh, I would say in this space, I could speak for mental health clinicians. COVID was like a gift and a curse for a lot of therapists, where there was this huge influx of a lot of new clientele. So therapists were like, yay, more business, but didn't realize how, be careful what you ask for. It could be overwhelming. So there was high levels of burnout. I saw it in the medical profession, just seeing on the news how there were high COVID numbers, and even people coming to therapy because they already had mental health, whether that be illnesses or just mental health things that they were grappling and functioning with on a day-to-day basis. But when you add on top of that being quarantined, it exacerbated those mental health issues to where they were getting worse. So there were high numbers of people who needed help, and they were reaching out. And I noticed a lot of therapists were experiencing burnout at a high rate, but they were still operating at level because they felt a sense of entitlement to their clients. Every great therapist, if they love what they're doing, they don't want to abandon their clients. And it's kind of in our code of ethics anyway. We shouldn't abandon our clients. But there's this sense of responsibility. I need to give my client the best version of me. But it's hard to do that when you're running on fumes, when you're running on empty. And I saw high numbers of that to where what I did for myself, and I encourage other therapists to do, was really focus on self-care for yourself and also for your clients, regardless of what they're coming to therapy for. Because if you're not taking care of your basic essentials, your basic necessities, there won't be much of you to give to your clients, and there won't be much of your clients to be really engaged in therapy. So I saw a really big push, not only for the conversation of mental health, but also for self-care, for the clients, and also for the therapists. So the influx of new clientele was not as meaningful as it would have been because it just seemed very overwhelming on all ends. So I think that's what I saw in this space, to where therapists had to take a step back, reflect, take a deep breath, and really, I also saw a lot of therapists change their entire business structure and say, you know what, maybe having high number of clients is not the type of business structure that I would like for my private practice. I thought it was, because I was counting dollar figures, but when I felt the impact of that and the negative effects it had on my mental health, I realized this is not what I wanted at all. And I saw a lot of clients, a lot of people coming to therapy, they were very open to the conversation. It almost seemed like 2020 brought in this great wave of people who were curious about mental health. And I thought that was amazing. The conversation got started. Granted, it took something as detriment as COVID and the pandemic to really start this conversation, but I think it was a healthy wave to have COVID start these natural, organic conversations about mental health. So I think this is something that's still ongoing, to where people are continuing the mental health conversation. And I also felt like even in the African American community, it became more destigmatized because the conversations were becoming a lot more where people, it almost seemed like it became a little trendy, where people were inquiring about their mental health, and regardless of the motivation behind it, I was just happy to see the conversation moving forward.
And Markin, how do you make time for joy? What do you recommend for medical professionals?
Okay, that's a good question. How do I make time for joy, and what do I recommend for medical professionals? I think it always starts with when you have to start taking care of yourself first. I know for me, the way I make time for joy is me and my family, we love to travel. We love to exercise. We love to, whether it's a Netflix night, go out, do things together as a family, or for me personally, it's just find time for myself. Something I started one day a week. I turn off all electronics. no telephone, no cell phone, no internet, no iPad. I won't lie. When I first started, I felt like I was about to lose my mind because I was like, oh, I'm missing out on the world. What's going on? But over time, it became very healthy to just shut everything off and to just really think and reflect. Something I always encourage my clients to do, and it terrifies them. Sit still in a quiet room for 5 to 10 minutes, and whatever comes to mind, journal about it afterwards. And you'll be surprised how something that simple is so terrifying. So I find time for solitude, to reflect, to do a little bit of self-assessment, to get away, and to travel and to enjoy the things I used to do, whether that's sports, whether that's things of arts and culture. I try to find time to make for that, and I would encourage medical professionals to do the same. One of the symptoms of depression is you lose interest in the things you used to enjoy. So if you find yourself losing interest in the things that you used to enjoy, really do a self-assessment of where you're at emotionally, because it could be that you're overwhelmed and you're just running on fumes and you don't even realize it. So make it a habit of parsing out a little bit of time every week to enjoy the things you enjoy, whether it's just reading a good book, going to your favorite coffee shop, whether it's, essential oils, bubble bath, getting together with good friends once a month, whether it's, let me try a new hobby, paint night, a new activity. Go back to making time for yourself, and that will require you saying, number one, telling some people no, being a little selfish at first, but that's okay. It's needed, because if you don't, like I said earlier, if you don't make time for yourself, then there won't be much of you to go around. So saying no is another great one, because being in the medical field, you're already working long hours. So by the time you get home, you have to physically recover. And after you've done that, now other people want a piece of you, whether that be family members, whether that be friends, other responsibilities. And learning to say no and learning to space your schedule out. Don't try to cram everything in 1 week. Do not try to be Superman. Do not try to be Superwoman. Take breaks, and don't always look at slowing down. The only time to slow down is when you're going on vacation. It could be a daily rhythm in your life. It could look like, you know what, I'm going to shut everything down at 5 p.m., 6 p.m. But of course, if you're in the medical field, I know the days run long, but when you're off, find those moments where you could just slow down and say, you know what, I'm going to have a me day where I do absolutely nothing, and feeling very unapologetic about that. So that's what I would encourage medical professionals to do.
That's very interesting. I think about your background in EMDR, and I'm wondering, how does joy and EMDR intersect? How can EMDR be helpful in this space?
I've never heard this question. How does joy and EMDR intersect? And how can EMDR be helpful in this space? I've never heard it worded like that. I think how joy stems from EMDR is that when someone comes to therapy with all of their trauma, they have all of these maladaptive thoughts, irrational beliefs, negative beliefs, a lot of self-loathing. And when you can work through that with EMDR, with the help of the bilateral stimulation, and start to bring the brain back to a place to how it once functioned before the trauma, there becomes a sense of, you gain a sense of joy, because now there's a lot of mental clarity. You see the world differently. How you think you were viewed by the world is different. And now there's more language for you to attach to what was once a lot of internal chaos within you. And now there's this greater sense of purpose, greater sense of resolve of what you want in the world, and what you expect from others, and how you plan on moving forward. And I think joy becomes a journey. You find that as you're moving forward and as you're healing. I don't think it's just this one, you're done with the EMDR work and then you just find joy. But I think it's more so discovered, almost like you're on this journey of becoming a better version of yourself. And within that journey, I think joy is discovered. So I know that's a tough question, because it's going to look different for everyone. It won't look the same across the board, but I think you'll get a sense of that joy and fulfillment as you're doing the trauma work and you're healing, and you're starting to feel more relief every time you leave a session with your EMDR therapist.
Lastly, we really want to make it plain and clear. So, what is EMDR and how does this all work? How does it come together?
EMDR stands for this long word called eye movement desensitization reprocessing, started by Francine Shapiro in the early 1990s. She's a licensed clinician, and it started with her moving her eyes laterally when she was dealing with a lot of stress in her life, and she noticed how much relief she would feel when she would do that, which so happens to be the same thing that happens to us when we're in REM sleep. Our eyes, we experience rapid eye movement because that's the brain's way of regulating a lot of the stresses within the body. But when trauma occurs, the mind goes into fight, flee, freeze, and this new one that a lot of therapists have called fawning, which is where we get a lot of our people pleasing, which is a trauma response. But EMDR, before I even get into the brain science part, EMDR is evidence-based, and what that means basically, it's been vetted by a lot of the top counseling institutions, the APA, a lot of the major entities within the mental health field, and it's been around for over 30 plus years, and it's been used pretty much with all diagnoses. But as you get into the more severe ones and the ones that deal with a lot of mental illness, such as mood and personality disorders, and where it encompasses a lot of dissociation, a lot of psychotic thinking, you would need a lot of consultation, and sometimes you might have difficulty doing EMDR if someone's not really in their right state of mind. But for the most part, for most diagnoses, EMDR is highly effective, whether that be anxiety, depression, whatever the case may be. But EMDR is a great tool that helps the brain to recover after a traumatic episode, because when someone experiences trauma, the reptilian brain, which is the lower base part of the brain, the back of the neck, it goes into overdrive. The prefrontal cortex goes offline, and then we have in the middle brain the limbic system. In there, it's called the amygdala, which goes off like a smoke detector saying danger, danger, alert, alert, and that never shuts off. So imagine having a traumatic experience at the age of 8, and that danger system from your amygdala stays on high alert all into your 20s and 30s, and you're always tense, you're always nervous, you always feel unsafe, you always have these negative beliefs, which are all trauma symptoms from that initial trauma. And EMDR comes in with the help of something called bilateral stimulation through the eye movements to help regulate the left and right side of the brain to learn to communicate again, to get those parts of the brain that have been in overdrive and have shut down due to trauma. It helps them all to regulate and to start working again. And your trauma, so think of your traumatic experiences as one big Thanksgiving dinner. Each EMDR session is like you're taking one spoonful of that big meal until we slowly chip away at all of it without it feeling so overwhelmed and intense. And lastly, EMDR is opposite from traditional talk therapy, because traditional talk therapy is top down, which is cognitive, emotion, and somatic. Cognitive, you come in, you're thinking, you're telling details about your experience. It may evoke some emotions, and you hardly ever feel any somatic symptoms from that conversation. Whereas EMDR is bottom-up approach, where the first thing you feel is the somatic effects of it. You feel it in your body, because that's where the trauma is stored. It's stored in your nervous system. And secondly, it evokes emotions. And thirdly, there's very little thinking involved. A lot of it, because, the trauma has to be broken up from your nervous system first, and the thinking that's involved on the back end is just your mind reprocessing a lot of the negative thinking, which is caused by bilateral stimulation. And bilateral stimulation can be done a lot of ways. Although the name, it started off with eye movement, you could do it with following a light bar. You could do it by tapping butterfly hugs, tapping each shoulder. You could do it by tapping each knee. You could do it by holding on the tappers. They vibrate left hand, right hand. Audio, if I had headphones on and I'm hearing a sound in my left ear and right ear, all of those entities, all of those examples will activate the bilateral stimulation to get the left and right hemisphere of the brain communicating again to help it to regulate a lot of the traumatic symptoms that you experience from your traumatic triggers. So I hope that answered it. Sorry for being a little long-winded, but that was a good question. That was a good question. Thank you.
That ends the questions for Markin. We'll move on to Dr. Harleen Hutchinson. Welcome, Dr. Hutchinson. We're so excited to have you here today to highlight your work in social and emotional wellness. So please tell us about your specialty.
I'm a psychologist, but I also specialize in infant and early childhood mental health, which means that I specialize in working with young children birth to 5 and their caregiver. This specialty is also unique and important in the fact that we know young children's brain are developing at a really alarmingly fast rate. So in doing so, I work with their caregivers to help them understand how their interaction with their children can be healing when they present with a wide range of issues at an early age. When we see children in the medical practice, we see that they're coming in with all different mental health issues, social emotional issues, and sometimes it's really important for us to recognize how those issues impact their social development and how it also impact their brain development.
How many years have you been practicing, and why did you decide to go into this area of our field?
That's a very good question to ask. I've been practicing for over 20 years working with young children from diverse cultures and backgrounds. And actually, I decided to go into this field because I started off my career as a public health educator back in New York. And then I transitioned into social work once I relocated to Florida. And doing those work experiences, working with families from diverse social cultures, especially our BIPOC families, I realized that young children at an early age were presenting with so many challenges, so many social issues. And they were being given mental health diagnosis and medication as young as 2 years old. And that was very alarming to me as a professional. And that really bothered me because the science of neurodevelopment have advanced so much as it relates to young children and how they function. Then, as I began to notice the increased rates of young children also being expelled from preschool due to challenging behaviors and other issues, I decided to return to school to pursue my doctorate with a specialization in infant and early childhood mental health, just to be able to provide the caregivers with that sense of hope and the parents that, we really need to look behind the waterline when they're being seen in physician's office or they're being seen by professionals who are actually just looking at the naked behavior and not looking beneath the waterline, just to understand what's driving those behaviors, especially behaviors in our BIPOC children. You see a lot of our BIPOC children are exposed to different things at an early age. And we really need to be thinking and wondering what is driving this behavior and thinking about how do I use not just science, but how do I use the data and the science of brain development to better understand young children.
What a meaningful journey, Dr. Hutchinson. Can you clarify what is infant mental health and how does this show up for medical professionals?
Thanks for asking that, because many professionals, when they hear the term infant mental health, they automatically imagine and wonder, what is that like to have a baby in therapy, right? But infant mental health really is about how well a child develops socially and emotionally from birth to 3. So the key to preventing and treating mental health problems in young children is to take an approach by an informed mental health principles, right, and practices. Because this approach also supports relationship health by guiding development of healthy social emotional problems and behaviors within the context of caregiving relationship. In a nutshell, what that means is when young children come to you, they're really struggling with social emotional challenges. And how those social emotional challenges, if they're not addressed within the context of the parent-child relationship, how they lead to mental health issues in the early school age.
What does anxiety and depression look like in infant mental health?
When we think of anxiety in young children, these symptoms basically can manifest as stomach aches, headaches, frequent temper tantrums, constant worry, just asking the same question repeatedly from their parents, right? And in babies, we see anxiety presentation as eczema or reflux. So we really want to try to rule out the medical issues first, because it's also very important to understand that young children develop in context of relationship. So if parents are stressed, their environment becomes too stressful. So they often absorb these stressors within themselves, which also manifests as anxiety for little children. So when we see these children in our practice and they're coming to us and mom or the caregivers complaining, this is what's going on with the behaviors, we ask, we assess, what's changed in the home? I want you to pause for a minute and think what's different. We also need to keep in mind that normative fears also and anxiety peaks at about 3 years old. So understanding that young children's emotional social capacities are also developed concurrently with their physical, cognitive, and verbal capacity also is the foundation that is also necessary in identify atypical and impairing anxiety disorder in young children. So what we mean by that is that we want to be sure to recognize how this may be limiting the young child's ability to participate in developmentally expected activities or routine, or it may be telling, or how it may be limiting their ability to develop new skills. When we think of depression, in terms of depression in young children, we need to understand that it is characterized by observable behaviors rather than the child's direct expression. We really, when we work with young babies and young children, they're not going to say, "Mommy, I feel sad," or "This," or "I feel worried." We have to look at their behaviors and also understand what their internal distress is. Because when we see depressed mood, it may present as sad facial expression, tearfulness that are actually persistent at times, or intense and pervasive across settings and relationship. When we think about settings, we're thinking about school, we're thinking about at home with different caregivers. And also when they're depressed and they present with irritability, right? These may present, this is what you see in your practice. Parents are complaining severe tantrums in school and at home, right? And what we also know that is that young children who are actually depressed, they show greater self-harm and tantrum behaviors such as self-biting and hitting. And these are the behaviors that you see in the preschool environment. So you have to be assessing and wondering and thinking about the frequency, the duration, and how is it impairing their ability to participate in normal, typical daily routine functioning within their school environment and within their home environment.
I think it's so important to talk about early childhood, to recognize adverse childhood experiences and resiliency. So, how can medical professionals focus on relationships to help improve their well being?
That's a good question. You know, as medical professional, we come to this field, we come to do our best, and we come to help the families and their caregivers that we work with. But sometimes we forget about ourselves. Like, we can pour from an empty cup. So as a medical professional, you really can start by learning how to pause and slow down. You guys are really doing a great job pouring from that cup daily by filling the cups of the parents that you serve. But there's also a saying, you can't pour from an empty cup, which means in doing the work that you do, slow down. Try to get to know the little ones and their parents. Just by extending that listening here, it goes a long way. And that also sets the stage for relationship building because relationship heals at all levels. We can also begin to engage parents more in conversation because our system is so designed in such a way that is so driven by insurance, is so driven by this mentality. We need to go, that we don't take those times to actually focus on those relationships, right? And have more conversation regarding their concerns. And if they suspect something, it becomes equally important to also refer these children to early intervention services because we want to make sure that we're really integrating services at a critical time when we have the opportunity to change those trajectory for young children's well-being. And early intervention also goes a very long way because we know that babies can't wait. So we have that critical window period of the first 1,000 days to ensure that they're getting their own emotional needs met, to mitigate all the mental illness that they're presenting with before they get to that elementary school years. But in order for you to do the job that you do and do it successfully, you really need to pause and slow down and really be filling your cup each day because working with little ones is very complex, it's very draining, and it also very emotionally draining in a sense that it's rewarding, but many medical professions are also parents themselves, and in seeing that some of those kids, their own emotional issue shows up in those relationships. So it's taking time to pause and reflect on those relationships. I think that that's a good way of having medical profession being able to fill their cup daily. Just take and not have that and not be left with guilt. Oh my God, I lost time because I wasn't able to finish this. Think about the relationship that you're building. Touching one relationship, healing one patient at a time. It also gives you that reciprocal approach where you're also doing your internal healing also. You're knowing that I've done the very best I can because I sat back and I listened to that parent or I listened to that caregiver.
That concludes the questions for Dr. Hutchinson. Moving on to Dr. Jasmine Duval. Welcome, Dr. Duval. It's so wonderful to have you share some wisdom with us on this podcast today. Can you tell us a little bit about your specialty?
So my name is Dr. Jasmine Duval. I am a licensed clinical psychologist in the state of Florida. And my specialty includes working with teens and adults dealing with mood disorders such as major depressive disorder or bipolar disorder, and also anxiety disorders such as generalized anxiety, social anxiety, and panic disorder.
How many years have you been practicing, and why did you decide to go into this field?
So I have been conducting therapy throughout South Florida and Central Florida for about 13 years, but I have been practicing as a licensed psychologist for the last 6 years now. Initially, I decided to go into this field to work with just a variety of individuals to help them see themselves more clearly. I enjoy allowing others to have a greater understanding of their self and feel more equipped to make the changes they're wanting to see in their lives.
We want to know, what is happiness to you?
So that is a great question. So I use a variety of theories and modalities in psychotherapy, but I really love using reality therapy. And from that lens, I would say that happiness is about being able to meet all of your needs in healthy ways, having a sense of balance, and really living a life that aligns with your value system. So, those basic needs that I really encourage my clients, myself, to meet are those needs for love and belonging, for freedom, for fun, for power, and survival. So I feel like happiness is that intersection of meeting all of those needs without taking away from the others. Personally, I really enjoy time with my family. I have a husband and 2 young children, so that is very rewarding for me. I feel really blessed in that area. But I also love time for just me. Happiness, I'm simple. It's some good jazz music and a cup of coffee. That's happiness to me, and being able to just breathe and live in the moment without thinking so far in the future. Just taking in the moment and the surroundings.
Well, so glad to learn a little bit more about you. Can you take a moment to talk about what is the difference, in your expert opinion, between anxiety and depression, and how do they present?
Okay, great question. So, anxiety and depression are oftentimes used interchangeably, and I think because a lot of times you see the two conditions together co-occurring, but they're very, very different. And while someone with depression can deal with anxiety, and someone with primarily an anxiety disorder can deal with depression sometimes, it is important for providers and for the individual to know which condition may be at the forefront, and sometimes those conditions can occur together. But anxiety is somewhat this general apprehension about what's going to happen or could possibly happen in the future. So, of course, we all deal with anxiety from time to time, but anxiety disorder is characterized by a pervasive sense of worry or nervousness, being overwhelmed by fear, being cranky or on edge. Sometimes when dealing with anxiety, you can be sweaty or shaky or feel like you're out of control. An anxiety disorder can sometimes include anxiety attacks or even panic attacks, which include these moments that are can be very scary. Sometimes they are confused with a heart attack because of the physical symptoms of anxiety, such as heart palpitations or chest pain or nausea. But anxiety at the core is a pervasive sense of dread or nervousness, while depression is primarily characterized by sadness. But depression is not just sadness, because we all experience sadness from time to time. But depression is kind of this ongoing sense of sadness, or sometimes feeling numb or gray, a sense of hopelessness, low energy, dwelling on the negative aspect of things. Sometimes people with depression may have suicidal thoughts. And also anxiousness can be a part of depression. A lack of energy, a loss of interest in things you once enjoyed. Depression can impact your sleeping and your eating patterns, sometimes eating more than usual or less than usual, which may lead to weight gain or weight loss, sleeping too little or too much, trouble thinking or concentrating. But that is basically depression. So the difference between the two basically has to do with the symptoms, but how they are related. So if you take someone who's dealing with chronic anxiety, a lot of times after a period of intense anxiety or an anxiety attack, that person may feel a sense of depression or hopelessness about the future and their ability to navigate anxiety in the future, or sadness about how to avoid a panic attack in the future. And then someone dealing with depression as the primary condition may have a sense of fear, anxiousness about their future, how the depression is going to play out for them, how the depression will impact their functioning or their life goals.
Well, what does intervention look like?
Intervention for depression, anxiety should definitely be tailored to the individual person, but research shows that the most successful intervention is a combination of psychotherapy and medication if needed. And I know that a lot of people may have some concerns about using a psychotropic medication. It is definitely something I encourage those dealing with depression, anxiety to talk with a provider that they trust. But intervention from a psychological perspective looks like really identifying those thoughts and behaviors that are not helpful or problematic, working to restructure those thoughts, committing to actions that align with your own personal life values. Specifically for anxiety, it may look like challenging those thoughts, those fears, by setting up little experiments with a provider to see how the feared outcome actually compares to the reality, because a lot of times anxiety leads to avoidance, avoiding different experiences, avoiding life, avoiding others. And intervention may look like kind of getting those tools to manage the anxiety and taking a step, seeing what those experiences actually look like using the tools provided in therapy. So intervention for most people may look like psychotherapy or talk therapy and medication if needed. If the symptoms are severe, where they're impacting the daily life, and medication does not always have to be long-term. Sometimes people may use medication until they're better able to control those symptoms on their own, and then continue in psychotherapy. So intervention is definitely personalized and should be customized to the individual.
All right. I think we've had an opportunity to really get to know you and your area of practice. What would you say are your top three actions that medical professionals can focus on to increase a sense of happiness for themselves?
So that is a great question. What I would like to do is to introduce medical professionals to the three C's of stress management, because I believe strongly overall happiness comes from a sense of being able to manage and navigate the challenges that life throws at us. So those three C's of stress management are control, cohesion, and connection. And control really focuses on looking at all of those things happening around you and in your life that you can actually control, such as getting proper sleep, eating well, um, experiencing enjoyable activities, taking care of yourself, going to your own medical appointments to make sure you're okay, using self-care, being able to schedule things on your calendar that bring a sense of joy. Cohesion really focuses on the narrative that we are telling ourselves about our life. So, why are you doing what you do? How does what you do align with your values? How do you want to take up space in the world? With cohesion, you may pull in your spirituality. What is important to you? How does your work from day to day help you to walk in a direction that you have for your life? And connection, the last C, is about connecting with other people. A lot of times, medical professionals are so busy and they find themselves always in caregiving roles. I think it's important to take time to connect with others who get to pour back into you, with others who may understand personally what you're going through. We don't want to find ourselves on an island, so it's important to make time to have meaningful relationships.
That concludes the questions for Dr. Jasmine Duval. Moving on to Dr. Gisette Smith. Welcome to the podcast, Dr. Gisette Smith. We are so happy to have you on, and we'd love to start with a little bit around your specialty.
All right, so my specialty, I am a licensed clinical psychologist specializing in diagnosing psychiatric conditions and working with psychiatric conditions, mostly depression, anxiety, addiction, and trauma-related disorders. One of my biggest specialties at this moment is psychological assessment. So I assess personality and functioning, intellectual abilities, academic functioning, and also attention deficit hyperactivity disorder, just to name a few. But that's one of my passions really, is I love psychological assessment and how it can provide assistance for kids in the school system and extra support that they need.
And how many years have you been practicing, and why did you decide to go into this area of the field?
So how long have I been practicing? So I feel like it's funny because I feel like I've been a mental health professional all my life, but I know that's not true. But so I've been officially practicing in the mental health field for a total of 13 years. So I've been working as a licensed clinical psychologist for the past 6 years. And then before that, I was working as a licensed mental health counselor. And the other part of the question, how did I decide to go into this field? It's funny, like when I think back on it, I don't think there was like a distinct moment that I decided to say, you know, I want to be in the mental health field. But I think back and I remember in like high school, ninth grade, I used to kind of write this little column, and it was like an advice column. And at that point in time, I knew I liked helping people. It probably was super unethical because I'm a ninth grader giving people, you know, advice and what have you. But it was funny. It was harmless. But I did find out that I liked working with people and speaking with people and helping where I could. But there was a distinct moment when I decided that I wanted to be a psychologist. So as I was practicing in the mental health field, I realized that to prevent my own burnout, I wanted to kind of mix up the different things that I was doing. So while I loved doing therapy, I also loved writing reports. I loved data. I loved research. So that's why I went back and decided to get my doctorate so that I can do assessments.
You know, Dr. Smith, sometimes we're with clients and we're always in tune with really what makes them smile, but we want to give you this time just to share what makes you smile, Dr. Smith.
What makes me smile? I like that question. So I love traveling. I love traveling to new places. I try to take a couple of mini vacations each year and at least one big vacation per year because I think that it's really important to unplug and just kind of be in the world, see things that I haven't seen before. But what really makes me smile is taking my children to new and fun places and seeing how they respond. So not only me getting to, experience something new, but witnessing somebody else and, seeing things through their eyes. That makes me smile.
Well, I thank you for sharing just a little bit more about yourself. You know, the level of happiness and joy has really been pushed by the pandemic, especially for our medical professionals who have given so much. Can you share about the reality of burnout?
That's a really good question. So the reality of burnout. So it's interesting because there's not a specific agreed upon really definition of burnout. It's not included in the DSM, which is the diagnostic manual that mental health professionals use for diagnosing. However, there's constantly studies focusing on burnout. And one thing that I can say about the reality of burnout, and especially how it relates to the medical field, is burnout is present in the medical field on a regular basis, right? So now kind of layer on the pandemic, and we can all imagine how burnout increased within medical professionals. So we have medical professionals, they're in a unique situation. So they are continuing to provide medical services and care to their patients, and they're simultaneously coping with their own difficulties caused by the pandemic. So while this is always true for medical professionals, they're always kind of juggling their own personal life and the responsibilities that they have. The pandemic put an extra strain on all hospital systems. There was like shortages in staff. So things that they might have been doing for self-care, maybe they weren't able to do anymore. So they weren't able to maybe take as many days off. They weren't able to, they might have been working longer hours. And then layered on top of that, they're constantly being on the front lines, in the front row of other people's trauma. So they're experiencing what's called secondary trauma, vicarious trauma, just kind of being in that area and witnessing people and being their support as they're, losing loved ones and coping with the significant illnesses and the after effects.
What are the signs of burnout and what helps?
Everybody's different. So I'll start with saying that everybody is definitely different with how they handle stress. But some of the things that we do commonly see, we see an increase in irritability. So a person that maybe is, usually mild-tempered, mild-mannered, they might be a bit shorter with people. Professionals often complain of poor sleep quality, feeling consistently tired and exhausted, and increasing in isolation, not really feeling like they can take on other people. Sometimes it presents somatically for people. They might start to have, GI problems, headaches, and in the more severe cases, a person really starts to experience like an increase in anxiety, depressed mood, losing interest in things that they were previously, very interested in. But just kind of a shift in feeling like themselves. And those are some of the common signs of burnout. And I'll talk about also the things that lead to burnout. So there's sometimes individual factors that contribute more to burnout, and then also external factors. So some of the individual factors, like perfectionism, and it's, there's probably a high level of perfectionism in the medical field. Right. So because there's a lot of dedication and a lot of hard work and a lot of, meeting goals and different things that it takes to become a physician and a medical professional. So some of those perfectionistic tendencies that might have helped a person when they were, attaining their goals might be something that's harmful for them because they are very strict on themselves. Other internal factors that might lead to burnout, people pleasing, so wanting to, make everybody happy, which we know isn't possible. Difficulty delegating to other people, so difficulty like accepting help, that can definitely lead to burnout. And in terms of external factors, so we have work demands, poor organization at work, poor teamwork, or just not having the support at work and just not having a social support in general. So those are some internal and external factors that could lead to burnout. So what helps is scheduling time for self-care. Like I know something that I do is if I put it on my calendar, like if it's not on my calendar, it's not happening. And I feel like that's the same for a lot of people that are extremely busy. If you want something to happen, you really have to schedule time for it. Because if you say, at the end of Tuesday, I'm going to get a massage. If you don't schedule it, then somebody's going to call you or something else might come up and then it just doesn't happen. So you definitely have to put it on your calendar and make sure that it's going to happen. Schedule yourself first, just as though you're scheduling a patient. So putting yourself on your own calendar. Again, allowing other people to help you, being able to delegate tasks. So not being, like I said before, not being able to delegate is something that does increase the likelihood of burnout. So we have to allow ourselves to understand that other people can help us. We're not the end all be all. We don't have all the answers. So other people can and will support us if we give them the chance. And of course, we have meditation, mindfulness, and just kind of, being able to be present in the moment and not living too far in the future, too, far in the past, and just kind of really being present. Those are some things that can help decrease the likelihood of burnout.
When mental health impacts our medical professionals, why is it important for them to invest in their well-being?
So it is definitely important for medical professionals to invest in their own well-being. As we often hear, you can't pour from an empty cup. So if you are not taking care of yourself, it's really difficult for you to provide assistance, support, and anything really meaningful for another person. So you have to be able to make time for yourself, not only on vacations, but I like to create mini mindfulness moments throughout the day. So even if it's just 2 minutes, just 2 minutes to sit, reflect, breathe, and kind of get yourself recentered again so that you can be ready and prepared and available to show up for the people that need you.
Well, we want to thank Dr. Smith, Dr. Duvall, Dr. Hutchinson, and Mr. Volamy for being on this podcast with us today. We also want to thank Be Well PVC for sponsoring this podcast and the entire team at the T.V. Roy Jefferson Medical Society for coordinating and creating a space for us to help our helpers and uplift some of the hardest working professionals in the medical field, whether you are in mental health or focused on physical care. We want you all to be mindful of your self-care. And so we thank you for tuning in today, and we encourage you to share this podcast with others.